Good morning, good afternoon, and good evening, everyone. Myself, Dr. Kumar Harsh, and I'm the oncology lead for Viatris Mylan Pharmaceuticals. On your screen right now, you can see this is the jam-packed agenda of the meeting. And so before we start with the agenda, of course, I would like to thank ISMPO and all the faculty members who have accepted to be part of this meeting, and all the audience who have joined in from different locations. And just to give a perspective, we have more than 450 registration and then that too from more than 30 different countries. So it's a good audience to have, and I'm looking forward to a good meeting. As you can see, for each and every session by the speakers, we have around 20 minutes, and there will be a buzzer or a bell at around 80 minutes. So that so this is just to give some time for the speaker to wind it up towards the end, as well as if we can get one or two burning questions from the audience or from the esteemed faculty over here. And so would also request the respective chairperson, Dr. Vineet Talwar and Dr. Chetan Deshmukh, to introduce their respective session speakers, as well as moderator or panelist. And just to tell everyone, I mean, this meeting is being recorded as a consent has been taken from each and every faculty member over here. And towards the end of the meeting, a certificate can be downloaded, which can be for the link for the same will be shared with all the members who joined today as a follow-up mail from the Mice Ideas team. With this, I would like to hand it over to Dr. Senthil. So Dr. Senthil Rajappa, who is the program director for the meeting, and he's a senior consultant medical oncologist at Indo-American Cancer Hospital and Research Institute, Hyderabad, India. Over to you, Dr. Senthil.
Thank you so much, Dr. Harsh. Welcome everybody for this International Masterclass 2022 on colorectal cancer. We had one on breast cancer a week ago, a very successful one, and I'm hoping that the colorectal cancer meeting will also be equally successful or even better. What we intend to do in the next couple of hours is to go through some basic information that has come up in the past year or so. There has been an exodus of data, should I say, in the past year. Some of them actually taking us back to where we were, nearly a decade ago. To discuss all this data, put it into perspective, filter it, and then give it to us, our three faculty. We've got faculty spanning across continents today. We have faculty from Europe, Africa, and of course, Asia. So we will get a perspective of all these people, depending upon where their geographies are, regarding the various changes that are happening in this field and changes that are happening really rapidly. So as was discussed by Dr. Harsh, we will first have 3 talks, basically on some biomarker workup, the treatment paradigms, maintenance therapy, second-line therapy, and so on and so forth. And then I will do a panel discussion trying to incorporate all this data into the cases that we will discuss. And as the panel discussion is entitled Consensus and Challenges, we'll try to see if we can come to some consensus on what we should be doing to our patients, depending upon the clinical situation, and what are the challenges and how to navigate through them. For the first session, it is my privilege to call upon Dr. Vineet Talwar, who is a very senior medical oncologist of our country and my very good friend. He will chair this session. He will introduce the speakers and take you through this very, very important session. He is Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute in New Delhi. Over to Dr. Vineet.
Thank you, Dr. Senthil, for the kind words. And to set the ball rolling, it is my proud privilege to introduce Dr. Daniel Rossini, who's a medical oncologist from the Department of Translational Research and New Technologies in Medicine and Surgery, Unit of Medical Oncology 2, University of Pisa, Italy. At the outset, I would love to visit Pisa and see how much is the latest tilt in it now. But just on the lighter side. Having said that, he would be thrashing about the nuances of biomarkers in metastatic colorectal cancer beyond RAS and RAF. Over to you, Dr. Rossini, please. Thank you so much.
Okay, thank you. I'm waiting for you in Pisa. Okay, so I'm Daniele Rossini. I work in the oncology unit of Pisa with Professor Cremolini. And today I want to thank the scientific committee for giving me the opportunity to present this very interesting theme that is biomarkers in metastatic colorectal cancer beyond RAS and RAF. Well, I have to say that generally when I face the patient for the first time in my clinical practice, clearly I have, according to international guideline, to test RAS, RAF, and also my macrosatellite status. I will not focus on that because I know that Claudia will talk about that and will focus on the ideal patient that has to receive one treatment rather than another. And so I will focus on that. I will focus rather on another theme that is quite interesting and important, and that probably will not change my clinical routine today, but probably in the future. And this is the genomic fragmentation of colorectal cancer. As you can see, there are a very huge variety, a sort of puzzle, a very huge variety of different alterations that could be highlighted in the colorectal cancer. I want just to start talking about probably the most famous and, also the FDA approval gene fusions alteration. We know, in fact, that generally when we have an NTRK gene fusion, there is an overexpression of TRK proteins with an overexpressed kinase function that really gives an important and aggressive disease. And we know also that FDA approved in the last years two drugs, the first one entrectinib and the second one larotrectinib, that not just in colon cancer, but also, in lung cancer and sarcoma or other cancer, a very high and impressive response rate. In fact, we have seen that, for example, larotrectinib in colorectal cancer obtain an overall response rate of 50%. It's quite impressive. We have to say anyway that these alteration gene fusions are very rare in colorectal cancers. It's present just in 1% of our patients, or less, I have to say, from my clinical practice. But, the main theme of my presentation is not just to talk about the effectiveness of drugs, but also of the correct identification of our patient. Well, I have to say that generally I think of a possibility for larotrectinib and entrectinib if I see a patient that is elderly, either a right colon cancer or a RAS and BRAF wild-type colon cancer. Moreover, probably the most important thing that gives me the idea of a possibility for an NTRK fusion is the presence of microsatellite instability. We know, in fact, that 7% of our patient, of our stable patient, probably has an NTRK gene fusion. And this is quite important to underline. Well, okay, now I know that I have my patient with an NTRK fusion, but how can I test if really he has an NTRK fusion? Well, it's not just a matter of one diagnostic method, but we have to know that we need both an NGS platform and a confirmation with immunohistochemistry. If we have not in our hospital an NGS platform, we can perform prior an immunohistochemistry. And then after that, we can confirm with an NGS platform using another hospital or another center. It is quite important because the correct selection of this kind of patient has to be performed with both the methods, so immunohistochemistry and NGS. Well, but there is another important alteration that in the last year has demonstrated some efficacy in colorectal cancer, and this is the HER2 amplification. We know that is another very rare alteration. In fact, is present in just 2% of our patients, but we know also that is more common in left-sided colorectal cancer and also in RAS and BRAF wild-type colorectal cancer. In fact, in this population is present in about the 5% of our patients. Well, it's important also to underline that we can call colorectal cancer amplified, HER2 amplified, not just as we can do with breast and gastric cancer, because we need an amplification in at least half of our tumor cells. And it's quite different from breast and gastric cancer. But we know that the drugs used in the past trials demonstrated a very effective. In fact, in the Heracles trial that used trastuzumab plus lapatinib, there were a response rate of 30% with a progression-free survival of about 5 months. And also using TDM1 in the Destiny CRC01 study, we can see a response rate of 45% with, again, a very impressive results in progression-free survival. But to be honest, we have to say that there are a very huge variety of small studies that demonstrated a very consistent efficacy results. We can see, in fact, that the median progression-free survival ranged from 4 to 8 months, and that the response rate ranged from 25 until, you can see, 50%. It's quite impressive, it's important. And a lot of different drugs were used. We have seen trastuzumab plus lapatinib, we have seen TDM1, but we can see also pirotinib and other drugs that is promising and probably will change our clinical practice. It's important also to underline that anyway, HER2 amplification is very promising also in terms of ongoing study. There is a very huge amount of studies that probably will change our practice, but there is one that I estimate probably the most important, and this is the Mountaineer 03 trial, a trial that randomizes or the standard of care with FOLFOX plus bevacizumab or cetuximab, or the experimental arm with FOLFOX plus tucatinib. This is an important study for 2 reasons. The first one, this is the first phase 3 study. The second one is that is enrolling more than 400 patients. And so I think that probably it will change our first line treatment. Really, I hope so. But again, I want to tell how is the ideal patient that could receive an anti-HER2 treatment. Well, we know that anti-HER2 treatment probably works well in RAS wild-type patient. We know from previous experience and subgroup analysis from the Heracles trial and also from the Destiny trial, we have to say that there is another important theme on RAS and KRAS wild-type, and that is that when we have KRAS and RAS and BRAF wild-type patient, it's very important to analyze also the HER2 amplification, because one, we can give to our patient anti-HER2 treatment in later line, but we know also that in a first line setting, generally, when we have an HER2 amplified patient, probably we have a patient that will not respond to an anti-EGFR treatment. So in my clinical practice, generally I test always during the first line the HER2 amplification in order to decide the best first line treatment. Okay, so we have seen gene fusion, we have seen the promising anti-HER2 drugs, but there is another drug that is facing on our clinical practice, on our really ongoing trial, and this is the anti-KRAS 12C. Again, a very rare mutation, 3%, but very effective. Nowadays, there are 2 drugs that are generally tested in ongoing trials. The first one is sotorasib with an half-life of 6 hours, and the second one is adagrasib with an half-life of 23 hours. This drug is very effective and really can bind the KRAS pathway, so blocking the RAF and PI3K signaling, and it's with a very specific and irreversible binding. We know also that it works like encouraging, like the anti-BRAF drugs. In fact, when combined with an anti-EGFR, we could obtain, as shown in the CodeBreak 101 and the Crystal-1 study, a response rate of 30% and a response rate for adagrasib of 46%. It's important also to underline that the 100% of patients could achieve a disease control rate. So we have to say that these patients are very pretreated patients, so very resistant patients, but anyway obtained a very interesting disease control rate in the 100%. There are again two studies that probably will change our clinical practice, and I hope so. The first one is the use of adagrasib plus cetuximab in a second-line setting versus the standard of care for FIRI. And the second one is the CodeBreak 300 study that tries to see if sotorasib plus panitumumab could give to our patient more respect to the standard treatment in later line, so trifluridine or regorafenib. But there is a last alteration that deserves attention. We have seen until now just drugs for small subgroup, 5%, 1%, 3%, but there is another important alteration, and this is the MGMT alteration. It is present in about 40% of our patients, so in a very huge part of our patient. And we have seen from previous study, mainly from the unit of Professor Petantonio, that it could be very effective. If we have got a patient with an MGMT deficiency, we could treat with temozolomide. Okay, I have to say that probably results are not so good. In fact, we have an overall response rate that range from 80% to 20%. But, you know, is anyway in a heavily pretreated patient our results. And we have to consider when we have no other drugs. And most important, I think that temozolomide in MGMT alteration is quite interesting for another aspect. In fact, as demonstrated by Dr. Morano, temozolomide can be used to reverse cold cancer in hot cancer. In fact, in the Maya trial, temozolomide was used as an induction phase in order to obtain a response, and then to use the addition of ipilimumab and nivolumab, obtaining an interesting overall response rate of 45% and a very impressive in a later line setting progression-free survival of 7 months. So probably I could stop here, but I would just have a spot on the future. We know, in fact, that there are several other drugs that in the future probably will be tested. We are not as far as H2 amplification or tract fusion, but I think that probably we have to look at this drug for, again, a very small subgroup. The first one is for RET fusion, sepercatinib and placertinib, but we have also to look at NRG1 fusion with the use of zenocutuzumab, but also with the use of neratinib for LBB2 mutation. But okay, there are a very huge variety of pieces of the puzzle. We have seen now different columns from the original slide, but I think that if we can find any of this alteration, we anyway could think about a treatment. So don't be negative, or better, be negative, because if we can't have any alteration, we can discover in our patient any alteration, anyway, we have to think that in a KRAS and RAS and BRAF patient, we could anyway select the ideal patient that probably will have a very strong benefit from the use of an anti-EGFR. So, as demonstrated by Randon in the PRESSING trial and previously in the PRESSING-2 trial, when we use an anti-EGFR in a very well-selected population that has no alteration, probably you will obtain a very impressive result with progression-free survival that are very, very high, probably higher than other treatments, any target treatment. So, in conclusion, the clinical scenario of target engagement is gradually increasing. We have CV2 amplification and tract fusion, but also MGMT. There is a paradigm change in metastatic colorectal cancer drug development that is ongoing from decades to years. A better selection could give more to our patient, also in terms of negative selection. I have to say that probably there will be always a missing piece of our puzzle, but you know, when the going gets through, the through gets going. So I want finally thank the audience, and hope that in the future we can discover more pieces of our puzzle. And so I leave the floor to my colleague Claudia Cardone. Thank you.
Thank you very much, Dr. Rossini. And now I think we go to the state of affairs. What is the targeted therapy in metastatic colorectal cancer? And for that, I proudly invite Dr. Claudia Cardone, who's MD and PhD in medical oncology and GI consultant, experimental clinical abdominal oncology unit from the NCI Fondazione G. Pascal, Naples, Italy. I hope I got it right, Dr. Claudia.
Thank you very much for the invitation
pleasure,
and congratulations to Daniele
Please.
for his amazing presentation. I will share my screen. Okay. Here we are. Hope you can see it. So, again, thank you for your kind invitation and thank you for your presentation. Here my disclosure. And here we go with my outline. I will talk about target therapy for metastatic colorectal cancer. We'll talk about targeting EGR, targeting BRAF, targeting hot tumors, and targeting angiogenesis. We go with the first part of the presentation. We talk about target therapy because we talk about personalized medicine. And to have personalized medicine, we need to talk of the goal of this kind of delivery, that is delivering the right cancer treatment to the right patient and the right dose at the right time. To do this, we need to identify, as Daniele was saying before, some biomarker, so characteristic that we can measure and evaluate as an indicator of physiological and pathogenic process or pharmacological response to therapeutic intervention. So basically, we need to focus on predictive biomarkers. So biomarkers were associated with response or lack of benefit to a treatment, and that are able to inform about treatment efficacy in a specific population. But we know that not all biomarkers have clinical implication, and ESMO has provided a very interesting scale that help us to identify biomarkers that have a clinical actionability, and so identify 6 levels of clinical evidence from the ESCATAR-1, so a target suitable for routine use, to ESCATAR-X, so a lack of evidence of actionability. And we know that in colorectal cancer, not all the biomarkers have really are actionable, but the only one that really have a clinical implication are RAS mutation, BRAF mutation, and microsatellite instability, so MSI-high. And we also know that we do not need next generation sequencing for identifying this kind of biomarker because we have cheap and very easy way to find them, like immunohistochemistry or PCR. However, next generation sequencing is very useful in order to identify patients who are suitable for clinical trial, or if you want to join some molecular program within screening, molecular screening program. So we go to the first part of our presentation, that is targeting EGFR. EGFR is a transmembrane receptor that activates at least 4 major downstream signaling pathways, and it's targeted by 2 monoclonal antibodies, cetuximab and panitumumab. 2 monoclonal antibodies with similar activity, similar efficacy, but we need to know 2 important things: the RAS status, but also BRAF status, and tumor location. We know that cetuximab is a chimeric monoclonal antibody because it's made by the murine part and by the humanized part, so it can give infusional reaction when administered, and panitumumab is a full humanized monoclonal antibody. So we need to know RAS status. Why? Because we know that we have 2 clinical trials, the Crystal trial and the Prime trial, who understood between 2013 and 2014 that we need a RAS extended wild-type status in order to prescribe in a very effective way these 2 monoclonal antibodies. Because as we can see here from the full report of the Crystal trial, when we administer cetuximab in patients with a RAS extended wild-type status, we see a better efficacy as compared to any kind of mutation or just a 12 or 13 wild type status. That's because RAS mutation keep RAS in an active way. So even if we block EGFR with our monoclonal antibody, the signaling pathway keep going. Another thing we need to know is the tumor location, because as we know, the tumor location is a prognostic and a predictive biomarker, because as we know from the meta-analysis from the Cardord, right-sided tumor have a worse prognosis in terms of OS and progression-free survival and response rate, but it's also a predictive effect, because we know that this kind of patient do not respond very well to anti-EGFR. So maybe in this case, it's better to use chemotherapy plus an anti-angiogenic agent. And here we have a full summary of the most important trial involving cetuximab and panitumumab in first-line setting. And as we can see here, the progression-free survival ranges from 9 to 13 months, according to the way in which we select our population, as Daniele was saying before, regarding the pressing status. But we know that targeting EGFR is not just a treatment, but is a full strategy, because when we administer continuously anti-EGFR to our patient, usually some mutations start to arise. And upon progression, we could find mutation, for example, in RAS. In that case, when we switch to chemotherapy plus anti-angiogenic as second line, we could have a decline in this kind of mutation. And this opened the way to a concept called rechallenge, that is giving again an anti-EGFR treatment to a patient after a change of chemotherapy and anti-angiogenic. And we know that the patient that benefit the most of a rechallenge strategy are patients who in that moment have still a RAS wild-type status. So it's very important to use a liquid biopsy or to retest with a tumor biopsy of our patient. But we also know that liquid biopsy can help us to identify novel strategy, like, for example, we are going to see in Capri-2 trial that we hope to have some preliminary results in the next future. But we also can have, for example, an intermittent way to give our anti-EGFR, like we have seen at the PROOF trial that has been presented at ASCO. Because if we give a stop-and-go strategy, so not a continuous way to give anti-EGFR, we can avoid acquired resistance, but we can also spare some toxicity to our patient. We change target, we go to BRAF. BRAF is kind of mutation that identify patient with a worse prognosis in terms of survival, in terms of progression-free survival. Usually are patients with peritoneal carcinomatosis and a high burden of disease. We have usually treated this patient with chemotherapy, and the TRIBE2 suggested us to treat this patient with an intensified regimen. It's the triplet, but we know that maybe a doublet is the same than the triplet as we had from the last meta-analysis presented by Professor Cremolini a few years ago. But now we have a revolution. It's from a new trial, that's the Beacon trial. Beacon trial introduced the full target strategy for this kind of patient. So patient after progression from first line were randomized to have a fully target treatment. It is encorafenib, binimetinib, cetuximab, where encorafenib is a BRAF inhibitor, binimetinib a MEK inhibitor, and cetuximab an anti-EGFR monoclonal antibody, as compared to a control arm that was chemotherapy. And we know that it was also a control arm based on a doublet strategy. So encorafenib plus cetuximab. And this doublet arm performed in the same way that the triplet. For this reason, EMA and FDA approved the doublet for this kind of patient. But now we are trying to move this target agent in first line. We have preliminary results from the ENCORE trial, but we are looking forward from Breakwater, where we will see the doublet as compared to the doublet in combination with chemotherapy as compared to control arm. We move again, we go to hot tumors, so tumors that could benefit from immunotherapy. And we know that in colorectal cancer, only a few patients can benefit from immunotherapy. And these are patients with a DMMR MSI status. MMR or microsatellite instability is a very powerful biomarker. It has diagnostic power because it helps us to identify patients with a Lynch syndrome. It's prognostic because it informs us of patients who have a good prognosis and maybe will not benefit of adjuvant setting in second stage, and are predictive because inform us of patients that could benefit from immunotherapy. And we can test it both with immunohistochemistry and PCR or with next generation sequencing. We know that immunotherapy has moved its first steps among this kind of patients, so patients with dMMR or MSI status, with pembrolizumab single agent or nivolumab single agent. But what is important is that the combination nivolumab ipilimumab has showed a very good efficacy, and long-term follow-up of Checkmate 142 trial demonstrated and confirmed this result. And thanks to this trial, we have now an approval of this patient for a second-line setting. But we know that pembrolizumab, so immunotherapy, is just a reality right now in first-line setting. In fact, pembrolizumab has been tested in Keynote 170-70 as compared to investigator choice chemotherapy in this trial. This was a phase 3 trial, very important, that showed the efficacy of pembrolizumab in the MMR MSI patient. We see that in the first month there was a crossing of the curves, then there was an efficacy for this patient with durable responses. However, there is a group of patients that do not respond to immunotherapy. We still don't know who are these patients. Maybe are patients with a different tumor biology, RAS mutant with high tumor burden. We still need to identify this kind of population. However, we know that also in terms of overall survival, the study was effective. Pembrolizumab was effective as a single agent. However, due to a rigorous statistical plan, the P was not reached because there was crossover and because there was a double endpoint. For this reason, the study is positive in terms of PFS, but not formally positive in terms of survival. We move again to another important piece of biology for colorectal cancer, that is angiogenesis. We know that we have several armamentarium for this kind of target, and we have bevacizumab approved in 2004 by the study of Ulrich et al. We have aflibercept approved with the Valor trial. We have ramucirumab that's not approved in all countries, but give some signs of activity and efficacy in the RACE trial. And we have a multikinase inhibitor, regorafenib, within the CONSIGN trial. But we're also very lucky because at ESMO 2022, we have a new molecule, fruquintinib, approved thanks to the FRESCO-2 trial. Fruquintinib showed efficacy in terms of overall survival, in terms of progression-free survival as compared to placebo in a heavily pretreated population, regardless of LONSURF, so trifluridine-tipiracil, and regorafenib use. So thanks to Daniela's presentation, my presentation, we had an overview of the last 20-year drug development in colorectal cancer. But is there any insight for future drug development? As Filippo Pertantonio said at ESMO 22, the answer is yes, because we have so many targets to explore in our signaling pathways, and we hope to develop them within the context of academic research. So here are my take-home messages. We should test for the most important biomarker in colorectal cancer, RAS, BRAF, MSI-high. We should always consider genetic counseling in patients with dMMR deficient tumor. And we should additionally test for other biomarkers if we have clinical trial, if we can ensure a personalized approach. We have always to consider academic research as the place to discover and validate novel biomarkers. And for those who are interested in target therapy, I suggest this handbook from ESMO. Thank you very much.
Thank you, Dr. Claudia. How often is the genetic counseling done in your patient setup?
I usually send all my patients with dMMR to genetic counseling, and I usually try to stick on the guidelines. So for example, if a patient has a dMMR and is RAS wild type, I send directly to genetic counseling. But if there is a BRAF mutation, I try to have some additional testing because maybe it's not a Lynch syndrome, but there can be an hypermethylation of promoter. However, we have a clinical trial in my center in order to try to understand in young patients or in patients where there is a familiarity, if there is any other syndrome in addition to Lynch syndrome.
Thank you so much. And all the patients are tested for the RAS, BRAF, MSI, MMR upfront, or you think that you do it at a later date, say after the first line?
All the patients are tested for this biomarker at diagnosis. Or high-risk adjuvant patient, or if there is a metastatic disease. We try to have also additional biomarker, but my institute cannot ensure personalized medicine to all patients. So if we have a clinical trial, we try to push. Otherwise, we try to let our patient join a molecular program because we think it's not fair to test and not to give the drug. So we try to test if we have an opportunity, or to send in another institution if they have other opportunity different from us.
Okay. Thank you so much, Dr. Claudia.
Dr. Vineet, can I ask a question?
Yeah, please, please.
Dr. Claudia, lovely talk. I have a question. Are there instances where you have used an anti-EGFR therapy for a right-sided RAS wild-type, RAF wild-type metastatic colon cancer?
Yes, I try to use anti-EGFR if patient has any contraindication to anti-angiogenic, or if I need to have response rate and the patient cannot benefit from an intensified chemotherapy plus anti-angiogenic, because we know that anti-EGFR plus chemotherapy still have a very good response rate. The problem is in PFS and in survival. So if the patient is not fit to have the full first line, I go for anti-EGFR, or if there is any chance that I need to send the patient to surgery immediately, and we know that anti-angiogenic leave us at least 1 month or 1 month or 6 weeks from surgery, I use anti-EGFR, but it's a really limited situation.
What would you prefer? Would you prefer an anti-EGFR plus chemo doublet, or would you prefer a triplet in a situation like that, where on the right side, for some reason, bevacizumab is contraindicated? Which one would you prefer of the two?
It depends on the patient, but maybe I would go for a doublet plus anti-EGFR. But if I really think that the triplet can give me something in terms of response rate, I go on the triplet, because I think it's also important to consider the dosage. Because if the patient is unfit for anti-angiogenic, I think it's unfit also for full dosage chemotherapy. That's the point.
Are you concerned about the liver damage that both irinotecan and oxaliplatin together can induce, especially if your patient is likely to undergo a liver resection?
No, I'm not concerned of
Okay.
oxaliplatin liver damage. I have many patients with a very high degree of steatosis, and I must admit that I didn't see so many hypertransaminasemia in those patients. So I use irinotecan or oxaliplatin according to the schema we use.
I'm talking about a triplet. Are you,
No.
when you're using FOLFOX IV in a situation like that, have you had instances where, the liver damage has been more than what you would expect when you're using a doublet? No, you haven't.
No.
Okay.
No,
okay.
I didn't.
One more question. This is corollary to what Senthil has asked. Suppose you have a patient who's wild type, right-sided, and you have given the first line as a VEGF with chemotherapy. Patient has progressed. Second line, would you use a VEGF, or would you use a EGFR, patient being a wild type?
That second line data with anti-EGFR not that strong. And if I think that the patient can still benefit from anti-angiogenic, I would go for anti-angiogenic, and I would use anti-EGFR in third line alone or in combination with chemotherapy.
Okay.
I have to say that I fully agree with Claudia. Really, I prefer to maintain the anti-VEGF inhibition and then to switch an anti-GFR rather than in a third line setting, especially clearly in a right side colorectal cancer, rather than to use in a second line setting, for the same reason that Claudia exposed clearly.
Well, thanks a lot. Over to you, Senthil.
Thanks so much, Dr. Vineet. We had a lovely session. We'll have some more questions during the panel. Please feel free to type your questions, send it across, and then we will reserve the best for the last, I suppose. Is Chetan around, Dr. Harsh?
Yes, Dr. Senthil. Dr.
Okay,
Chetan
so
Deshmukh.
it gives me great pleasure in inviting my dear friend and colleague, Dr. Chetan Deshmukh, who's a senior consultant medical oncologist at the Dinanath Mangeshkar Hospital in Pune. He will share the next session and take us the third talk and the panel discussion. Over to you, Chetan.
Thank you, Senthil, and thank you, Mylan, for the invite for this wonderful meeting. Am I audible?
Yes, you are.
Yeah, thank you. So it's an interesting session coming up on the maintenance aspect of metastatic colorectal cancer, and it's going to be delivered by Professor Arnold Dirk, who's the director of the Asclepius Tumor Hamburg Cancer Center, serving 7 community hospitals in Hamburg, and he's also the head of Department of Oncology, Hematology, and Palliative Care at AK Altona, Hamburg. Before this position, he served as the director of the University Cancer Center in Hamburg and held positions at the university departments for oncology and hematology in Halle-Wittenberg, Freiburg, and Berlin. Between 2015 to 2017, he also served as the director of the Institutos UFD Oncologia in Lisbon, Portugal. Over to you, Professor Dirk.
Thank you so much, Dr. Deshmukh and Dr. Rajappa, for this kind introduction and the invitation to share with you some thoughts about, now going to the maintenance strategy and what we will be, let's say, learning from here. So I just open my desktop and try to share everything so that you can see this nicely. So. And then we get started. Please give me an okay if you see the presentation now in a good way. Yeah, wonderful. Claudia is nodding, so therefore I think she should come to its best. Okay, first the disclosures of interest. And we have to generalize when we think about maintenance and further line treatment that all of this belongs to an entire strategy. This entire strategy starts with induction treatment. We'll say what we just learned, to choose the best systemic treatment in the beginning, then to look on localization and response, where metastases are, how the patient is responding, and then have, let's say, this spread of this algorithm, because if we have patients with oligometastatic disease, we clearly have the best maintenance and post-induction treatment, which is resection or ablation, and I'll come to this. And I will talk about the minority of patients, or is it the majority, of those which are no candidates for ablative strategies. And here we go to de-escalation maintenance, discontinuation of the treatment, maybe adding a different compound. And this, however, this decision is to be made after 8 or maximal 16 weeks of treatment for which of these groups this patient is belonging respectively, and what we can be doing here. When we think about ablation strategy, we have guidelines saying that we should be using the surgical resection or the ablation toolbox. What does it mean, ablation toolbox? Ablation means that, of course, liver surgery is the standard of care, but however, I'll show you a picture here with a single mat, which is centrally located in a patient who has been nicely responding to chemotherapy. And this is unresectable technically, because you can see this by localization. It's centrally located, so therefore there's no need that this, and there's no way that a surgeon can remove this, because it's on the peripheral venous confluence, so therefore impossible to resect. So therefore, in any case, we should also have this whole range of ablation treatment strategies with us. And the key question for this ablation strategy, ablation, I repeat myself, as the best maintenance, because it really preserves patients from continuing on chemotherapy is then only the question, which of these perioperative treatments, which of the perioperative treatment intensities is necessary. And here we have several factors which we do have to consider for making the best treatment decision in this perioperative setting. However, we do not yet consider biological factors. We make the decision today about resection, non-resection, ablation and no ablation simply on the pattern on clinical characteristica, but we have no hint, for example, whether we should treat a BRAF or a MSI high patient differently in terms of surgical or local ablative approach than a wild type patient, etc. However, coming to the main topic, the post-induction strategy. So what do we mean with de-escalation maintenance, discontinuation, or simply adding a different compound? Well, we have learned that any chemotherapy or any treatment is better than no treatment, as maintenance treatment, when we discontinue the inductive treatment. I think the purest design is the Focus 4 trial from the UK, randomizing between active monitoring and capecitabine, will say only a single agent fluoropyrimidine after 16 weeks of inductive treatment. And then you can see clearly that in terms of progression-free survival, but not overall survival, but progression-free survival clearly favors the continuing of capecitabine. So is there a value of maintenance treatment per se? It is, because maintenance treatment, if not associated with toxicity, controls the disease for a long time without risk for deterioration of the patient. What should we do with molecular targeted approaches? Here, the very new ESMO guideline just been online, available from the ESMO guideline group of 2022, says that whatever we have as induction treatment, we will then have another maintenance treatment strategy. You can see that for oxaliplatin-based chemotherapy, the discontinuation is clearly standard of care, and maybe the continuation with fluoropyrimidine plus bevacizumab is to be seen as the best treatment option. For patients which started with anti-EGFR, I will use a few words about this because it's very new data coming to it from that. And for FOLFIRI, we do not yet know what we have to do. However, the recommendation is to also discontinue combination treatment when it is possible. First question, what is about bevacizumab maintenance? Bevacizumab maintenance works. We have learned that continuing bevacizumab, either a single agent or in combination with the fluoropyrimidine, adds to improved progression-free survival. And we take the totality of these four trials, we also see a strong trend towards improved overall survival. What is the role of anti-EGF receptor antibody as maintenance treatment? Here we do have less data. Maybe the best data today comes from this 248 patient randomized trial looking after induction of FOLFOX and panitumumab, and then randomizing patients which have stable disease after, or even a response after 16 weeks, to either 5-FU plus panitumumab or to 5-FU alone. We can see that the continuation of the anti-EGF receptor antibody also positively interacts with progression-free survival and, at least by trend, with overall survival. So therefore, the ESMO recommendations for targeted agents as maintenance treatment are very clear. Maintenance is active and is to be seen as an attractive part of the strategy because it allows us to discontinue treatment. We do not have to continue chemotherapy until patients are really suffering from toxicity. We can discontinue and to, let's say, de-escalate after 4 months. The active maintenance improves progression-free survival and maintains a longer quality of life, but it has no impact on overall survival. And for the molecular targeted agents, we have a clear signal. After bevacizumab and chemotherapy, we should continue with the fluoropyrimidine plus bevacizumab as a level 1A recommendation. For combinations with anti-EGFR and chemo, also 5-FU plus anti-EGFR should be seen as standard of care. And none of these single agent biologicals, neither cetuximab, panitumumab, nor bevacizumab, nor immunotherapy, and no targeted approaches are single agent good candidates for a maintenance treatment. It's always a fluoropyrimidine-based combination. Coming now to the re-challenge and second line, and here my difficulties with the definition do already start. We do have clearly proven treatment sequences, and you have already been discussing this in the last discussion part. If you have had a first-line chemotherapy plus anti-VEGF treatment, and we have these different molecular situations, or whether we have had a first-line chemotherapy plus anti-EGFR with RAS wild type or with MSI high dMMR, we may have different treatment options. For all patients which are RAS mutant and which have been starting with anti-VEGF first line, then they should also have a second-line chemotherapy with anti-VEGF. And Dr. Cardona has just nicely explained the different treatment options for the continuation of anti-VEGFs also in second line. We have 4 phase 3 trials, all of these with overall survival improvement with 3 different drugs, bevacizumab in the TML trial, which I had the privilege to lead, aflibercept and ramucirumab. So super clear evidence here. Also for patients with RAS wild type disease and the question, what is then the best second-line treatment? Dr. Rossini has already been answering in the discussion session that he would prefer to go then for second-line continuation of anti-VEGF and then have this third-line anti-EGFR. And I do completely agree that this is the best treatment way. However, theoretically, it may be also an option to have a second-line chemotherapy plus anti-EGFR, but the better way is to reserve the anti-EGFR for third line. If we do have BRAF mutants, of course, we do know that then the targeted anti-V600E and anti-EGFR, like in the Beacon trial, should be seen as the standard of care for those patients. And clearly for patients with MSI high or dMMR status, which have not undergone first-line treatment with specific immunotherapy, should then have the immunotherapy as single agent or even better in combination as second line. And for those with anti-EGFR, well, if they are MSI high, the same story applies. And if they are RAS wild type, then also, of course, the same story applies for those which have been treated with anti-VEGFs in first line. So second line standard is clearly second line chemotherapy plus minus anti-VEGF. However, the most difficult decision is, what should we really do after patients are progressing a first line and even a first line maintenance treatment? Should they go directly to second line, or should we think about reintroduction of the first line? It could be a good idea if patients have been not progressing on the first line treatment and it has been discontinued or de-escalated for maintenance reason, to reintroduce first line treatment. So what are clinical decision criteria to discriminate whether patients are better treated with a reintroduction or better treated with a real second-line treatment? Well, we have different clinical characteristics which could help us to make the decisions. For example, if I have a long time from first-line treatment discontinuation to progression, then the reintroduction could be good. If it's short, then patients should move to another chemotherapy or another therapeutic principle. If you have a successful treatment in first line with great response, even a complete response, then of course this is super promising also for second line. If we have patients which maximally have achieved stable disease, then maybe a second line would be better. If you had a maintenance treatment with high intensity, then maybe the 5-FU-capecitabine continuation is better. If there is no maintenance, then the reintroduction may be a good idea. And also clearly toxicity from first-line treatment, whether it's resolved or non-resolved, is a key factor for the decision-making here. However, we have learned over the last years that clonal selection of sensitivity to chemotherapy will be crucial in the future, and already in clinical trials it is today. And we have seen that we have this principle of clonal selection and clonal detection. We have learned this story because it's so easy to learn stories from RAS wild type and RAS mutant disease, because that's a binary marker, either being RAS wild type or being RAS mutant. And you can see this on this nice cartoon. if you have these light blue cells, which are RAS sensitive, then you have a successful treatment. For example, with cetuximab, you have the reduction of this sensitive clone with the growth of an insensitive clone. And then after a treatment holiday, you may see a repopulation of the initially sensitive clone. And then clearly it could make sense to reintroduce the first-line treatment. Well, this is to find and this is to detect on the ctDNA perspective. You do know ctDNA, let's say the plasma DNA, and the RAS detection on plasma DNA probes is not so difficult. And we can see that we have a molecular selection which may show us whether patients have RAS wild type or have a RAS mutant situation, or whether other clones will occur. And we have learned this, and the credits here go to both Italian colleagues at this call, but also to the Italian community at all, because we have to learn from 2 academic trials that this is a super powerful tool for further treatment decision-making. The first trial, Dr. Rossini involved, is the cricket trial, which was using, let's say, the reintroduction of a ctDNA-based RAS wild-type patients with a treatment with irinotecan and cetuximab. So let's say the continuous ctDNA assessment was done over the treatment course, and only if patients were maintained or again RAS wild-type by ctDNA, they had a high chance to respond again and to have a long continuation of this anti-EGFR treatment as a result of the clonal selected or clonally sensitive RAS wild-type clone detected by ctDNA. And another Italian trial from Dr. Sartori Bianchi was also using this in a more or less similar approach or separate approach. In this trial also, they were clearly correlating that responses only were observed in patients with ctDNA being RAS wild type, and the sensitivity was independent from time from last anti-EGFR treatment. But 2 more interesting findings have been learned from this Kronos trial. First of all, not all patients with RAS wild type did respond. Only 2/3 of patients had a benefit, whereas 1/3, despite being RAS wild type by ctDNA, had progressive disease. And the second is that new clones and new clonal mutations occurred as a result of the treatment with anti-EGFR receptor antibody. So the key message, the pressure of an anti-EGFR treatment leads to the development of further clones, which can be then seen as the driver of the disease. So having said this, we can then also say that for later line treatment, we have other treatment options. So next to this sequential treatment, including the reintroduction strategy, we have other molecular targeted approaches, which can be seen as further line treatment standards. Those are the new thymidine analogs, the new tyrosine kinase inhibitors, also novel VEGF inhibitors, as well as other molecular targeted agents. And wherever we look to and to whatever analysis we go, the molecular targeted approaches in colorectal cancer does work in a few subset of patients. Mutations like FGFR fusions or RAD or NTRK, as well as ALK and RAS mutations, do very rarely occur in colon or colorectal cancer. However, HER2 may be a relevant target for the future. The data here from, for example, trastuzumab and pertuzumab in chemorefractory patients, or here the combination of tucatinib plus trastuzumab, or here the antibody drug conjugate trastuzumab deruxtecan have shown nice results in refractory patients. And the same applies to the specific RAS G12C inhibitors, maybe drugs for the first line next time, but for the moment being, we can only say that the efficacy we have been seeing with KRAS G12C inhibitors have been observed in refractory patients. And we will learn also in the future whether these drugs will be good drugs for the further treatment, a single agent or in combination with anti-EGF receptor antibodies. And Dr. Cardona has already nicely outlooked that anti-VEGF principles like regorafenib or chemotherapy alternatives like gefloridine, tipiracil are interesting options for late line treatment, as well as fruquintinib. Here's the first of these trials, FRESCO-1 trial, FRESCO-2 trial. Dr. Cardona has just shown the results from ESMO this year. So clearly this is a new pan-VEGF TKI, which will add benefit for a very late line stage. Okay, last slide. This is the summary, and the summary is, let's say, looking on the therapeutic sequence. We have seen that sequencing treatment in colorectal cancer means having good decision in first line, but then also having a long interval post-induction. Always consider surgery and ablative treatment as the best post-induction treatment whenever feasible. Also think about second line, but also reintroduction. And reintroduction can be also happening in third line and fourth line. So it's really continuing of caring for patients. And only this will, let's say, add to the overall totality of offering a very high overall survival period. Thank you for listening.
Thank you, Professor Dirk. That was an excellent talk. Are there any questions for Professor? Maybe there'll be questions during the panel discussion. May I request Dr. Senthil Rajappa, Senior Consultant Medical Oncologist at the Baswatarakam Indo-American Cancer Institute, to invite his panelists and start the panel discussion.
Thank you very much, Chetan. Lovely talk, Dr. Arnold. We will discuss some of those issues that you mentioned in your talk during the course of this panel discussion. We have all our speakers as part of the panel. We have Dr. Daniel Rossini, Dr. Claudia Calderon, Dr. Arnold Dirk. The next slide, please, Harsh. We have Dr. Jerry from OK. So we have Dr. Somashekar, who is a very senior surgeon. We have Dr. No, go back, please. We have enough time. There's no hurry. Right. So we have Dr. Chanyut, who is Associate Professor and Head of Medical Oncology at the Vajira Hospital University in Bangkok, Thailand. The next one. The next slide, please. Yes, thank you. Dr. Jerry Tan Chung Bing is medical oncologist. He is at the University Cebu Medical Center. He's from Philippines. We also have Dr. Omonde Ogude. Please pardon me if I'm not pronouncing your name properly. He's a specialist physician and medical oncologist from Nairobi. So as I mentioned earlier, we really have a cross-continent panelists so that we get a perspective of how this disease is managed in each of these geographies. Can you let me share my screen? Yes, thank you. All right, so as I mentioned earlier, we will have two cases that we will discuss. I'm so sorry. We will have two cases that we will discuss today. The first case will revolve around a patient with oligometastatic rectal cancer to the liver. So we will talk about the induction regimens. How do we choose? And then we will ask Dr. Somashekar how he would sequence the resection and what are the issues of concern. In our second patient, we will talk about everything that Professor Arnold spoke about. And of course, looking at liquid biopsy and how you should be incorporating this in daily practice of metastatic colorectal cancer. So we start with this patient who is a 37-year-old male. He presented with bleeding per rectum of 4 weeks duration. He did not have any other symptoms. His grandmother had breast cancer. He was on Levipil 500 milligram twice daily for a seizure disorder, which is well controlled. He hadn't had any seizure in the past 2-3 years. His clinical examination was unremarkable except for a growth felt 5 centimeters from the anal verge. That is the colonoscopy picture. That's the growth that you're seeing. It's a very classic appearance that you're seeing on this colonoscopy. The rectal growth was biopsied and it was a poorly differentiated adenocarcinoma. So that was the report. The immunohistochemistry on this was done. It was the basic immunohistochemistry confirmed it to be a primary from the rectum. Interestingly, the CA was normal, but the alpha-fetoprotein was grossly elevated. It was just over 5,000, which came as a big surprise in a patient who had a growth in the rectum. So the next step was to do, he had a CT scan, and then we went on to do a PET CT scan. And on the PET CT scan, you're seeing these two large liver metastases. This was segment 5 and segment 8. 7.1 centimeter. I'm sorry, Dr. Somashekar, I don't have the 3 dimensions put up here. That's typically a medical oncologist's way of looking at sizes, I suppose. The largest diameter, I'm so sorry for that. And 4.4 centimeter, 2 liver metastasis, lesion in the mid 1/3 of the rectum, multiple perirectal nodes. So that's what we saw on the PET CT scan. And the enhancement pattern of the liver lesion on the scan was like metastasis. It was not like a hepatocellular carcinoma, because the point was whether this guy had 2 primaries, because the alpha-fetoprotein was so grossly elevated. So Dr. Somashekar, let me start with you. Should all these patients who have oligometastatic disease to the liver also have an MRI at the time of diagnosis, because the anatomic delineation and pickup might be better, or a good CT scan as part of a PET CT is enough? Dr. Somashekar? Harsh, is Dr. Somashekar?
Dr. Somashekar, you are on mute. Let me.
Yeah,
actually,
I'm not logged in as a panelist. I'm just put as an attendee, so I have no control.
Oh no! Oh no! We are so sorry for that, Dr. Somashekar.
No problem.
Please go ahead.
Yeah, so somebody has to mute and unmute me. I have no buttons left on my screen. They have put me as a attendee. No problem.
As long as you have your laparoscopes and robos in place, I think that's
no
good.
problem.
So please go ahead.
Thank you very much. This is a very interesting case. Number one, to answer, should we do an MRI? Yes, if I'm going to have a liver limited disease like how it is, and then when you have more than 1 lesion too, MRI of the liver I would always prefer, because the reason is MRI dedicated liver would actually show it could be a bilobar disease or more number of nodules than what a PET scan can show. And my treatment approach might totally change if I know there are multiple lesions like 4 or 5 or bilobar or other. So if it is multiple lesion as it is seen here before I do liver directed surgical therapy, yes, definitely I would always ask an MRI liver in addition to this.
Excellent.
Go
ahead, Dr. So.
Yeah, number 2, you asked me how we would approach this particular case.
We'll come to that in a moment. We'll come to that.
Okay, then fine.
We'll go ahead. So let me ask our Asian colleagues, Dr. Jerry, is that also a standard protocol that you would follow in your hospital?
Yeah, we usually will submit this case to the MDT to have a MDT discussion, since I'm a medical oncologist, and we also need inputs from our surgical colleague. And it's usually a routine practice in our institution to do an MRI also for the liver.
Okay, good. So that's absolutely right. For people who are listening, if you're looking at doing some liver targeted therapy, it's always good to do an MRI to make sure that you pick up all the necessary lesions that are of relevance in managing this liver in a patient with oligometastatic disease who should probably be treated with a potentially curative intent. So in that puzzle that we started with, the AFP being just over 5,000, this was the immunohistochemistry review of both the rectal biopsy and the liver biopsy. So it was SAT-B2 positive, CDX2 was positive, both CK7 and 20 were focal positive. The Glypican was positive, HEPAR1 was negative. So the pathology diagnosis was a poorly differentiated carcinoma, adenocarcinoma of the rectum with hepatoid differentiation. Dr. Daniel, I have to turn to you because this is where the googly was, and then we just got stuck as to what the next step in a patient like this should be. Should be managed like the usual, adenocarcinoma of the rectum, because from the hepatoid differentiation in adenocarcinomas of the rectum seemed to be confined to just case reports when we went ahead and looked up. So what would be your thoughts, in a situation like this? You have to unmute yourself, Dr. Daniel.
Well, I have to say that
Thank you.
clearly it's an unusual presentation. I have to say that probably I will test anyway for the classical KRAS and RAS and BRAF and
Okay.
satellite instability. And then I just probably will decide after clearly an MDT discussion the best first line treatment. I have to say that this hepatoid differentiation is clearly unusual, and thus I clearly see the clear origin from the rectum. I probably will decide for a first line treatment based on the key RAS and BRAF status.
Okay.
These are left side colorectal cancer. Is probably will be wild type. I will choose for a doublet plus an anti-GFR probably.
Right. So because of its rarity, we exactly did what Dr. Daniel said. Though there were some, reports to say that a hepatoid differentiation comes with poorer prognosis, but it didn't tell us that we have to manage this any differently from a classical colorectal cancer. So that takes us to the next step. Let me ask Dr. Chanyut, in your hospital, as part of the molecular workup, would you just confine to doing a RAS, RAF, MSI, or would you do a broader panel? Dr. Daniel gave a lovely talk regarding the relevance of many other markers in today's management algorithm. So what would we routinely do in your hospital, Dr. Chan?
I usually use a limited panel, especially lab and MSI, because NTRK or otherwise are not reimbursable in my country. And also that it is quite rare. I think that it is not rational at this moment, especially the first line setting. So I think that I usually use a limited panel, last draft and MSI only.
Okay, Dr. Omondi, would you also do a limited panel?
Exactly. I usually use limited panel.
Okay, so both of you would, Dr. Claudia, in an academic setup, what would you do?
I will test, as Daniela was saying before, for the canonical testing, and for sure, as you are now moving for DPD polymorphism, because I will choose for a doublet plus anti-GFR or anti-angiogenic in case of RAS mutant. And if I have clinical trial, I will enroll for one of them.
Okay.
It's a young patient.
Yes,
and
it's a young patient.
I will send for genetic counseling respectively from MSI status 37. It's a early onset clinical colorectal
Absolutely.
cancer.
So we would probably look at doing some genetic counseling irrespective of the MSI in a patient who is 37, I suppose. Dr. Somashekar, would you in your center do a DPD polymorphism? Because routinely in our hospital we don't do. But do you think that it's worthwhile doing it for all patients who are going on, 5FU infusion? Because in Europe, it's part of the ESMO guideline, I suppose.
It was actually not done since couple of months. Now we have started asking. Our central lab is doing it, not in the exact hospital I have, but we have a central lab based for the cross institution. Yeah. Dr.
Arnold, would you routinely do a DPD polymorphism before starting patient on 5FU infusion?
Let me anecdotically say, as responsible for the ESMO guideline, we were not keen on having this in the guideline because we were not deeply convinced that it's necessary. However, the registration body, will say the EMA, the European drug registration entity, taught us that we should do this, or the registration of 5FU is now tied to the testing before. So therefore, formally, we do have to do this. However, we are not convinced that it is that necessary. Although most sites now have integrated this into their therapeutic algorithm.
Okay, so it's not a compulsion, though as part of the regulatory requirement, it actually might be. Right. That's right. So a limited panel is good enough, DPD polymorphism, preferable to do, though not a compulsion. So this patient underwent a broad panel NGS. We just have a 51 panel gene panel, oncomine panel in our hospital. So we did that. So the RAS, both the K and N RAS were wild type. The RAF was wild type. The MMR done by, so the NGS also showed an amplification in the HER2 gene, which was confirmed by immunohistochemistry, and it was HER2 3+ positive. So you're clearly seeing a HER2 amplification confirmed by immunohistochemistry. So you have a young patient, 2 liver metastasis, liver metastasis, rectum middle 1/3, perirectal lymph nodes, and this is the molecular workup that you're seeing in this particular patient. As part of a thesis, a postgraduate thesis, we also did the CPS for this patient. The CPS was 3. At this moment, to my knowledge, this does not add any value to the management of these patients. Dr. Claudia, would you agree with that the CPS does not have any relevance to deciding on the management of this patient, right? So it was purely part of some thesis work that we did a CPS. The TMB was not done. So let me get back to the surgeon. Dr. Somashekar, would you, in your multidisciplinary clinic, sequence this patient by doing chemotherapy first? Systemic therapy, should I say, rather than chemotherapy?
Yeah, this particular patient, I just had a quick glimpse with the images you showed, and you confessed that you don't have the entire liver, but I could see that it is in more than 2 segment radical.
Right.
One, if I need to achieve an R0, I would end up doing an extended right hepatectomy and left with about 30% segment 2 and 3. So in such particular patient, I would put it in MDT and request my medical oncologist to give me a neoadjuvant systemic so that I can reduce the volume of liver resection. And I can preserve 1 radical. So basically out of 3, 2 is involved in this. Technically, we can achieve an R0 at a very significant cost in a rectum. So this patient, I would actually prefer. We are also part of this International Liver Met Survey, which has got more than 22 lakh of liver resection. My data is also there. If a tumor is more than 5 centimeter, more than 1 lesion, 2 radicals are to be resected. We always found that neoadjuvant treatment followed by resection had a better outcome.
Excellent. So we would do neoadjuvant therapy for this patient before we took this patient for liver resection. Dr. Jerry, would you like to take questions 2 and 3? Would you use a doublet or a triplet? And if you're using a monoclonal antibody, what would you use in this particular patient, Dr. Jerry?
Yeah, thank you, Santil. So in our country, we usually do request limited panel testing. And with regards to the questions of doublet versus triplet, because of financial consideration, and since the patient is quite young, and I think he doesn't have any comorbidities, then he might benefit from the use of triplet regimen. So in terms of monoclonal antibody, so this is a question that's oftentimes asked, but rarely we will be able to give it to our patient because of financial consideration. But if it's not an issue, then perhaps I will consider the use of doublet agent plus an anti-VEGFR, even though there's concern with regards to the washout period. But my concern here is patient is HER2 positive. So it might give me an idea that there might be some form of resistance to treatment with an anti-EGFR agent.
Excellent. So because of the HER2 that's positive, your thought process is that there is resistance to the anti-EGFR, and hence, so would you use a doublet plus an anti-VEGF or a triplet plus an anti-VEGF, Dr. Jerry?
I think if
the
regimen will give me that opportunity to use the combination of triplet plus an anti-VEGFR due to a higher response rate. Yes.
Excellent. So a triplet plus an anti-VEGFR is one of the rational choices in a patient like this. Dr. Chanyut, would you agree with Dr. Jerry regarding the triplet plus an anti-VEGF?
Because this patient has the left side and right side last and last. I think that based on the triplet study, FOLFOX and plus panitumumab is enough. Based on the response rate that's superior to the bevacizumab, I think that in the first line setting with potentially resectable disease, at the left side with wild type last and last, I think that FOLFOX and panitumumab is my choice.
Okay, so you would use an anti-EGFR agents. That's typically the controversy that comes up. Dr. Daniel, I want to pass that question on to you because you did mention about this during the course of your talk. What would be your choice of neoadjuvant therapy in this patient who is HER2 3+ positive?
Okay, I have to say that it's not very simple to answer to this question. Really, in my clinical practice, I will not use an anti-EGFR in a HER2 amplified patient, at least in the first line setting. So I would prefer probably a triplet plus an anti-VEGF, so bevacizumab. But I think if we have a different optic and we are looking for resection, probably also a doublet will be the best solution. I think that in this case, probably I will prefer a triplet plus an anti-VEGF because it's a very young, because I think that probably is the best solution considering also the load of metastasis. They are very huge and probably we need a very huge shrinkage. I don't consider the use of anti-EGFR in this patient because it is HER2 amplified, and we know from previous subgroup experience that probably is not the best choice in the first line setting.
Great. Dr. Daniel, the use of anti-VEGFR looks like a logical choice. What's the incremental improvement in response that you would get by the addition of an anti-VEGF agent to a triplet? Is it a significant increment, or what would you think? Because one of the aims of the immediate treatment that we're using in this patient is to get the best responses possible. So, and considering the point that Dr. Jerry mentioned regarding the washout period, you need to wait for 4-6 weeks after the last anti-VEGF agent, and that prolongs your duration of chemotherapy. So, that's again a bit of a difficult decision to take, though it can sound very simple and straightforward there.
No, it's very difficult to question because really I know that probably you have to wait 6 weeks until the resection. Anyway, I think that using the triplet plus an anti-VEGF, you can obtain 60% of overall response rate. So there is also a very important shrinkage that has to be considered, and probably could in any way, based on some works of Peter Antonio, could reach the level of a doublet plus an anti-EGFR. So I think probably if we want a reduction of the disease, the use of a triplet plus anti-VEGF probably is the best solution.
Excellent, very good. Dr. Arnold, would you also choose the same regimen?
I tend to, but my questions are, what are the surgical consequences in terms of tumor shrinkage, yes or no? And as I've seen these two mouses, they have been relatively big in size, but however, they have been, let's say, with or without shrinkage, the surgical approach would be the same. So therefore, I'm not insisting of having every millimeter as tumor size reduction. We are treating for prognostical reasons, also for the primary tumor, to see that the primary tumor is also, let's say, decreasing, but we are treating not to the max of treatment intensity. This is obviously as it looked like, not needed. So therefore, I would say here, I would consider safety also first. I would clearly not go for an anti-EGFR here. I'm even not sure whether I would go for a triple chemotherapy, despite our Italian friends like to do this, but I'm not sure whether we really need this. We really need this add-on here. And my take would be a doublet plus minus anti-VEGF here.
Okay, so we've got so many choices. We've got a triplet plus an anti-VEGF, a triplet only, and then we have a doublet plus anti-VEGF agent. But I'll leave it to the lady to make the final decision. Dr. Claudia, what would be your choice of therapy for this patient? Because I know it's a difficult decision. There's no one right answer. So what would you think would be the most appropriate, should I say?
I totally agree with both of you. My only question is, are we sure that the patient will not respond to anti-EGFR? Because I have some experience with other HER2 patients. They responded to anti-EGFR because we know this information from subgroup analysis. So if we take literature, I would go for triplet or doublet plus anti-angiogenic. However, I'm not that convinced that avoiding EGFR is a good decision, because anyway, we can prescribe it and it's a left-sided tumor. So maybe we will make the patient miss something. So I'm not that convinced. Maybe I would go for anti-angiogenic based therapy. However, I don't think EGFR is such a bad idea anyway.
Okay.
If Dr. Rajappa, if I may ask, I think we all agree that the choice of chemotherapy is here not the really super important thing, because the overall prognosis of the patient will not rely on the choice of chemotherapy. It will be relying on the choice whether at some point you can remove the liver met and the primary tumor safely. Yeah, I think that's
absolutely. Absolutely.
I think you made the driving force.
So yes, you're absolutely right. So I think we need to get to resection. That's the most important thing here, because resection is likely to make him a long-term survivor, at least in 25% of cases. So how to get there the best way without damaging too much of the liver is the most important question here. And I think everybody has made a very important point. So the points that I gather are, it's important to get to that resection. Most seem to be tending towards using an anti-VEGF therapy based on subgroup analysis, but there's also a thought that it's not inappropriate completely to use an anti-EGFR agent. So you would probably use it sometime during the course of therapy, if not necessarily the first line. So it's not an absolute contraindication to use an anti-VEGF, anti-EGFR therapy is what I gather. Now, the fourth question, I'll quickly answer that question and move on. I put up there saying lenvatinib or not. So the reason why this question came up was in some other subsites where this kind of a tumor was described. There were situations where patients have been put on a combination of this TKI along with chemotherapy, and the responses were a little better and the PFS was better. So that's the reason why I put it up there. So, not really up for discussion, because that was also discussed in our multidisciplinary tumor board. Now, let me bring all of you to this, table where, we've kind of summarized all the recent data. I want, some discussion on the paradigm and the CARO-5 study. Paradigm, for me, though, it clearly proved that right versus left got very strong prognostic value. Is the predictive value of right versus left for an EGFR/VEGF therapy weakly predictive? Because if you look at the curves that I will show you in the next couple of slides, this is progression-free survival curves sitting one on top of the other. Absolutely no predictive value in terms of the progression-free survival. Predictive value there in terms of overall survival. Again, the hazard ratio is not very impressive. 0.82 for the left-sided population and 0.84 for the overall population. 20% of patients in this trial were right-sided colorectal cancer. Absolute difference for left-sided, which is where you would use the anti-EGFR therapy, is about 3 months. For the overall population, surprisingly for me, I thought it will come down for the overall population. It actually went up for the overall population. Again, when it comes to the right-sided tumor, the curve sitting one on top of the other. So let me ask Dr. Claudia, what are your thoughts on the paradigm study? Because the reason why I'm asking this is that in a country like ours, where EGFR therapy is very expensive, and in a patient who's not oligometastatic, who's not going to go for resection, and considering that the quality of life on anti-EGFR therapy is also not as good as what you would get on anti-VEGF therapy, if somebody comes with a tight shoestring budget, I am less tempted today to push them to take an anti-EGFR therapy, because that's prolonging overall survival. What do you think about this data that has come out? Because this is a much better done study compared to the CALGB study. So what are your thoughts, Dr. Claudia? And then I want to ask Dr. Daniel and Dr. Arnold for their views on paradigm. Dr. Claudia, let me start with you.
Sorry, I was muted.
Okay.
I think we have robust data about the prognostic value of tumor location and on the use of anti-EGFR in left-sided tumor, and on the controversy on right side. And Paradigm adds some data on it. I think that, as I was saying in my presentation, we might consider a different way to give anti-EGFR, especially for a matter of toxicity and a matter of budget. I'm really interested in the stop-and-go strategy, for example, because if the patient is really responsive to anti-EGFR, a stop-and-go strategy can spare toxicity and can spare also in terms of pharmacoeconomy. So I think that if we really believe that the patient would benefit from anti-EGFR, he should receive it. But maybe it's not giving it in a continuous way, the best way. We might have data coming from improved trial or other stop-and-go strategy that can help us to give it in a different way and an effective way. That's my point.
Okay, Dr. Daniel, strongly prognostic, poorly predictive. That's my summary of the paradigm study. Your thoughts on that?
Well, I think that probably if we look at progression-free survival when we analyze as a point the use of anti-EGFR, probably we will never see respect to the doublets plus an anti-VEGF the best treatment, but because we have never seen a study that demonstrated the superiority in terms of progression-free survival. Generally, I prefer to use anti-VEGF in right-sided colorectal cancer because I look at overall survival, and I think the studies and the meta-analysis demonstrated such a benefit. Clearly, I really don't consider a huge error using an anti-EGFR, and I also consider that the analysis of Claudia really demonstrated really is interesting. I have to say that generally in my clinical practice, I consider the results of Paradigm appealing, and okay, I prefer in the first-line setting to use an anti-EGFR in a first-line setting, an anti-EGFR in left-sided colorectal cancer because of the previous experience, and I think also looking at Paradigm that we need, I think, a more robust overall survival in order to analyze this study.
Right, you need a more robust overall survival benefit. That's right. Dr. Dirk, what are your thoughts on this? For me,
well,
yeah, go ahead.
I would slightly contradict what Dr. Rossini was just saying, because we do have so much data now together. And in fact, you have not mentioned the strategic trial, which have been also seen at ASCO this year, also another anti-VEGF versus anti-EGFR combination from the French group. And we have now 6 randomized trials looking on this. And all of these 6 have a common finding. The hazard ratio for overall survival in left-sided ranges from 0.77 to 0.83. And all of these trials are somewhere in between. So we'd say we have a 20 to 23% improvement of overall survival likelihood for the left side. Highly statistically significant. And that's what it is to gain. On the right side, the hazard ratios range between 0.84, this is the best, to 1.28. This is the worst, 28% detriment. And overall, we have a super clear picture for the left-sided, and we don't have a clear picture for the right-sided. And for the left-sided, your question, considering financial toxicity, financial burden, completely agree. It's 20% of improvement of overall survival likelihood, 20% more or less. Okay. It's not a rocket improvement. If I don't have the money, then I would not put the money to this. And I think we have other targets in oncology where we spend our money better than in a 20% improvement of overall survival likelihood. But it is 20%. We cannot neglect it. Therefore, we have to play with this data.
I entirely agree with what you're saying. The right side is not that very great. Prognostically, it does pad the overall survival for the right side. It's somewhere around 24 months. For the left side, it's about 37 months that you're seeing. So a huge difference in terms of prognosis. But I entirely agree with you that for the left side, it's 20%. If yes or no, the answer is a yes. But is it huge? The magnitude of benefit is not that very great. Dr. Jerry, your Asian view on Paradigm, because all of us come in, from a place where, finance is always a problem. Not all patients can afford an anti-EGFR.
Yeah, it's quite interesting data, and it's quite supportive of the use of anti-EGFR in the left-sided tumor. But again, because of practical reason, we still oftentimes, if it's a maintenance strategy, we'll give our patient capecitabine plus bevacizumab, regardless of the sidedness of the primary tumor, mainly for financial reasons.
Right. Correct. So I entirely agree. So whenever somebody can take an anti-EGFR for a left-sided wild-type tumor, we go ahead with it. But we don't probably push if somebody's coming with a tight budget. Dr. Omondi?
Yeah, so I'd agree with my colleague. I think there's good data for left-sided for doublets and anti-EGFR. And I think for the patient discussed, that would be my choice. Although, the HER2 positivity, I think there's good data to show that's a negative predictive value for anti-EGFR. So if there's an alternative, and there is one, which is your anti-EGFR, your anti-angiogenic, I'll definitely opt for that instead with a doublet. And of course, there's an option for the triplet therapy as well, which I don't think is a wrong choice.
Right. Dr. Daniel, your thoughts on the Cairo study. Again, something very similar, unresectable liver metastasis, response rates were better with the anti-EGFR. But ultimately, if you look at the PFS and the reported overall survival, no difference between the two at all. And this was, again, a well-conducted study. These were patients who were RAS-RAF wild type. Again, something very similar to what you're getting in the Paradigm. Better responses, but outcomes not very different between the two. Do you think it's just a reflection of the Paradigm study and what we know earlier, or do you think this, because you're seeing that the response rates are certainly better? Dr. Daniel.
Really, I want to stress this concept. If we look at the progression-free survival, probably we can't see the real benefit of anti-EGFR in left-sided colorectal cancer. I will better see the overall survival. So I think that clearly it's mandatory to use an anti-EGFR in left-sided colorectal cancer. Anyway, it's not the progression-free survival the main point. So I think that we have to look at the benefit in overall survival and response rate moreover. So I fully agree that the best is an anti-EGFR in left-sided colorectal cancer.
Right.
Really, there are no such, there are no huge results in progression-free survival, but we can see in overall survival, we can see a response rate, and this is my main object when I face my patient, really.
Dr. Arnold, do you think we should choose our patients better? Is it time we started using something like the pressing panel to choose our patients so that the benefits of using an anti-EGFR therapy will be better than what we are seeing in all these studies? The guidelines don't recommend, but time and again, when you speak to experts, they will all say that, you know, if this is present, then it's better to avoid using an anti-EGFR agent. So what are your thoughts? How quickly do you think we will be able to incorporate the pressing panel in daily practice? Will we ever do it at all?
I think there's much strength behind this, and I think we will have a further marker which will indicate, as you were saying, with non-sensitivity or part resistance, rather than having super, let's say, sensitivity. But for pressing, Dr. Rossini is clearly the man to speak about, since he has been involved in the development of this.
Dr. Rossini, would you
want to
take
yes,
that?
I have to say that, yes, it was on the original paper in the pressing panel. I have to say that clearly, also in my clinical practice, I don't use the pressing panel. We have not such very expensive, I have to say, but it was a study. We demonstrated that point. We hope that now that where the NGS platform is now available also in our center, we will consider that. But I have to say that nowadays my clinical choice is not based on the pressing panel. Yes, I analyze KRAS and RAS and BRAF, analyze also a HER2 amplification at baseline, but it's not my routine to use the pressing panel. In a study, okay, I will analyze all these genes. I will not use in my clinical practice, I have to say, I have to admit it's now a study, and probably I hope in the future it will be possible to analyze for each patient these all these characteristics, but it's not my clinical practice, I have to admit that. Okay,
so at this point in time, at least as this panel goes, we will only use sidedness, and we will use RAS, RAF, MSI as the most important ones to determine the choice of treatment for our patients. Though we have a lot of knowledge regarding the other molecular markers, we will at this point in time not use that knowledge to make our decision regarding which monoclonal antibody to use. So that's where we stand as far as choice of monoclonal antibody is concerned. Let's get on with what we did for this patient. So for the reasons that I thought that the incremental benefit of an anti-VEGF agent would not be very great. We discussed this in our multidisciplinary tumor board. We decided, and also concerned about the washout period before we took this patient for a liver resection. So we went ahead and did a triplet for this patient, no monoclonal at all. After the first cycle, he was admitted with grade 3 mucositis. We did do the DPD polymorphism at that point in time, but there were no polymorphisms that were detected. Interestingly, we also added lenvatinib 4 milligram from cycle 2 based on some case reports and case series, not from colorectal cancer, but from other anatomical subsites with a hepatoid differentiation of those adenocarcinomas. So this is the reevaluation that was done after 4 cycles. That is the tumor on the left. There's hardly any tumor on the right. So those are the PET images. Again, Dr. Somashekhar, I don't have the MRI picture, but I at least have the lesion size now from 7 centimeters come down 4.7 into 4 into 2.6. And some 4.5 centimeter to 2.5 centimeter. And this time the MRI picked up 2 additional lesions, query hemangiomas, query metastasis, and they said they can't completely rule it out in a situation like this. the alpha fetoprotein, which was 5,060, had come down to 16.4. The CEA was always normal, so it continued to remain normal. What are the next steps, Dr. Somashekar?
Yeah, so patient has now received almost 3 months.
Four cycles.
Yeah. Okay. I can see that there's a response, not a dramatic response, but
okay.
Yeah, it's a good response. Normally, I found that at the end of 4 cycle, if the desired resectability is not reached, by giving additional more cycle, it's unlikely we're going to make it operable. So the philosophy at this moment is I will do a proper volumetric analysis, which is built in with the new softwares to see an FLR. As I can see in a non-cirrhotic, which looks in this patient with a normal healthy liver. Normally, we always do a biopsy of the healthy liver in addition to the lesions when you did it. And if there is no CLD and no cirrhosis, which looks so, and OGD-scopy rules out portal hypertension, we would do a volumetric analysis. And if FLR is more than 30%, which looks so in this patient, we would go for liver first approach, and then we would do the rectum as a secondary. And if in liver we are able to achieve R0 resection, then we would do a staged rectal surgery next.
Okay, Dr. Omondi, would you also take a strategy like that, or would you, in your center, it's more often both done at the same time? If both are done at the same time, would you want to do some radiotherapy to the rectum before they went ahead and operated?
Yeah, look, I'm speaking from a medical oncology point of view.
Yeah, I understand. We just have Dr. Somashekar, unfortunately, today.
Yeah, and I think this would be obviously done within the context of a multidisciplinary team. And, obviously a lot of this has to do with the expertise of the surgeon involved, the hepatobiliary surgeon, what they're comfortable with. I'm assuming it's an MRI with liver contrast.
Yes.
That would obviously, for the most part, help us differentiate in between that and the hemangiomas. But it really depends on what the surgeons are comfortable with. Of course, if they're willing to do a staged procedure, that's what they'll do. Or alternatively, do it at the same time. Just depends, all within the context of that meeting. Yeah.
Right. So this patient,
I will just add one more issue. If you look at the liver met survey of all the liver metastatic disease surgeons who are in all the trials, which are also we are part of it. If it is not a rectum, where it is a ultra low resection, like a colon resection, with a simple single lobe liver resection, we always combine both when minimal access. But if it is more than 2 lobes, here it's an actually extended resection in the liver and another in the rectum. In this particular area, the morbidity of combining both, even if you do minimal access, be it lap or robot, is quite high. So that is only place where we go for a short course radiation to the rectum. And during the recovery phase, which we buy about 5 weeks, we would do a liver first approach, then come back to rectum.
Okay, correct. So the same thing was done here. So it was a staged approach, but when they did an intraoperative ultrasound, they found 4 liver metastases. We were all the while showing only 2 liver metastases. So all the 4 were resected with negative margins. So what would you next do, Dr. Chanyu? So this guy has had 4 cycles of FOLFOXIRI or FOLFIRINOX, or whichever way you want to call it, a triplet. So would you continue systemic therapy? And if you're continuing, how long would you continue this systemic therapy? When would you address the rectum, Dr. Chanyu?
It is quite difficult to determine because you continue lenvatinib connect with the chemotherapy. I still do not really know that the response, whether the response from the chemotherapy or lenvatinib. This is my first question. But if I use only the FOLFOXIRI plus or minus the biologic, I think that I will continue the treatment after surgery for about 2 to 3 months. And I think that radiotherapy is sometimes it is not necessary. If you get the response very well perform the chemotherapy, I think that radiotherapy can be omitted.
Okay. Dr. Jerry, what would be your choice of adjuvant therapy in this patient?
Yeah, I will just continue the patient with two more months of FOLFOX, and perhaps again have another MDT discussion regarding the benefit, as you flash right now, of using a short course RT before addressing the rectal mass.
Dr. Claudia, would you agree with this strategy of using, we dropped the irinotecan in the post-surgery setting, and we just did the FOLFOX and then did short course radiotherapy and then 2 more cycles of FOLFOX? Would you agree with that strategy? If you had started with a monoclonal antibody, what would you have done post-surgery? Would you have continued the monoclonal antibody along with the chemo?
So first, if the surgeon would be not able to go straight on the rectal surgery, I will continue chemotherapy. I would go with FOLFOX and short and then FOLFOX. If I would have chosen bevacizumab, maybe I would have interrupted it.
Okay.
If I would have used anti-GFR, I would have continued it.
Okay, if you're using why would that difference be, Dr. Claudia?
For the reason we were saying before, anti-angiogenic needs a longer way to before surgery. Anti-GFR just need a few weeks. So considering timing of surgery, I think it's important to keep this in mind.
Okay, and would you stop the treatment at some point in time, or let's say a perioperative 6 months, or would you continue, because you said you would do the anti-EGFR also, so you will continue the anti-EGFR plus the FOLFOX for a total of 6 months? Right?
Actually, I would adopt the strategy of perioperative once I know that the patient is NED, so with no evidence of disease.
Okay, so as soon as the rectum also comes out, you probably would continue and complete the treatment and stop. Dr. Daniel, would you also do that, continue the antibody, do that perioperative strategy, and once all the disease is removed, then probably stop it?
No, generally, I think that after the resection of the liver, I will opt for resection of the primary tumor, and then after that, I will continue with the same regimen used before for just 6 months of total treatment.
Dr. Somashekar, if there is a clinical complete response in the rectum, can you avoid an APR for this patient?
Very, usually wait and watch policy, if you have a clinical CCR, is in a condition where it ends up with an abdominal pen resection with a permanent stoma. Because we know that it's not a level 1 evidence, even though in selected right patient who are kept on right option, we can do that. In this patient, it is going to be a sphincter preserving surgery right away.
Okay.
So since it is a sphincter preserving surgery, there is no permanent organ ablation in this patient. Even if I have a clinical CR, I would go ahead and resect, because there is no much change in the quality or a permanent stoma.
Excellent. So since you're going to be able to preserve the sphincter, there's no merit in thinking about preserving that, is what you're saying. Dr. Arnold, you're nodding your head, so I assume that you're muted. You're muted.
With this point, I'm right. I'm not so sure whether I would recommend a 5x5 gray short course radiation, because we are here in the mid-third. We have a clearly resectable disease. If we don't have a CRM positivity, we don't make any prognostically good thing of using 5x5 gray. That's a mid-third which could go, in most cases, up front to surgery without radiation.
Okay, straight away surgery without radiation.
Yeah, because we really have to say, radiation is not adding to the overall prognosis at all. And we do have, for the liver met, we have the situation that the patient has a high risk to relapse and to die from metastatic disease. So therefore, we are not really doing something for good if we use 5x5 gray. I'm not even sure whether we need 5x5 gray if the patient would have not had any liver met at all. But in this case, no way.
A nice point. So that's a very point to really ponder about. So Dr. Som, let me ask you there. So I think it's a very logical point that Dr. Arnold made, that you probably don't need to do radiation because this patient is, if at all, going to die of systemic relapse. And is there really a relevance to doing radiotherapy before doing rectal surgery? What do you routinely do, Doctor?
Actually, I would little beg to differ. I'm very well aware radiation in rectum is not going to give you overall survival benefit and just a local regional control. There are some point in oncology where local control actually outweighs for the quality of life in a pelvic tumors and head and neck. because once the local recurrence happen, it's quite miserable. Quality of life is poor. They end up with bleeding symptoms where you cannot actually use anti-VEG receptor, and you don't have a fit patient who can take sequential chemo, where even if he recurs, he can live another 3 to 5 years. So I would look at a rectal MRI. If it is T1, T2 or T3, but not nodal disease, yes, I'm okay to omit radiation. But if it is a N+ disease on an MRI, they are going to recur in first 48 hours in pelvis, where we know a stage 4 liver lung limited disease can routinely live 5 years as of now. And you would have a recurrence in pelvis between year 2 to 5, which would really jeopardize the quality of life of the patient. Pelvic recurrence are very miserable. You may not have OS, but take the patient's view, it's totally different. And you need a fit patient to give sequential chemo to keep him alive 5-7 years. And you will not have that if a patient has a fistula obstruction, ends up with stoma bleeding.
I think it's two different perspectives. One's a medical oncologist perspective, and the other being a surgical perspective. Both right in their own ways. But I think typically we would do radiation therapy before we went chasing the rectum. So as I go to the next case, there's a question in the chat box. I'll ask Dr. Claudia. There is a question in the chat box saying, why not use trastuzumab and chemotherapy in the first line for this patient? Why do we have to break our head over anti-EGFR and anti-VEGF? Dr. Claudia, can you take that question, please?
Actually, we do not have a phase 3 randomized trial supporting this. In the context of a clinical trial, I will do it. Outside the clinical trial, I will not, according to my national system.
Right. So we've got 10 minutes to go, so I'll quickly run through this case. We just need to discuss a couple of important points regarding maintenance, anti-EGFR, and monitoring. So this is a 52-year-old lady. Ultrasound of the abdomen done for fatigability and abdominal discomfort showed multiple liver lesions. The colonoscopy showed a growth in the sigmoid. CA was elevated. CA19-9 AFP were normal. PET CT scan was done. Studied with liver metastasis. So this lady had a moderately differentiated adenocarcinoma. RAS-RAF, wild type, MSI, and HER2 were negative. So this lady was started on FOLFOX and panitumumab. She had 12 doses over 6 months. The oxaliplatin was stopped after month 4, that means after 8 cycles. She also had a grade 2 neuropathy and a grade 2 skin rash diarrhea from the anti-EGFR agent. Very good response that you're seeing here. That's the sigmoid, that's the liver post-treatment. The sigmoid is metabolically almost negative now. Dr. Chanyut, what maintenance therapy would you choose for this patient? She's got grade 2 toxicity from the anti-EGFR agent at this point in time. So only 5FU, leucovorin maintenance or capecitabine maintenance, or would you do anti-EGFR only or a combination of the two?
Due to, I think that this patient has extensive tumor burden, I think that maintenance treatment is unavoidable. In this case, I think that maintenance with panitumumab is too toxic. So I choose 5FU and leucovorin as a maintenance treatment. But may I suggest that based on the study called the IMPROVE study, you can use stop and go treatment between chemotherapy and anti-EGFR in the stop and go fashion as well. But you use the continuous treatment for 6 months. I think that maintenance treatment with 5 is enough. So this is my thought.
Okay. Dr. Omondi, your choice for maintenance therapy in this patient?
I guess I think what's important is always speaking to a patient and understanding where they are in their journey and what they want as well. For me, combination would obviously be the best with anti-EGFR and 5FU. And it would depend on how they've tolerated it as well. Not all patients have the same adverse reaction, and sometimes you're able to get good skin control with the drugs and they tolerate it well. And if they are, why not continue?
Okay.
If they're struggling with their treatment and if it seems to be anti-EGFR driven, then you can look at just the 5FU based maintenance.
Okay.
So that would be my approach, really understanding where we are with the patient. Obviously, you want the maximal control if you can, and if it's reasonably tolerated, why not continue?
Okay, so that's probably the best thing to do. Do some maintenance, number one. If the anti-EGFR toxicity is acceptable for the patient, a combination of 5FU and anti-EGFR would be the optimal maintenance therapy for this patient. Dr. Claudia, during the course of the previous discussion, you did mention a couple of times about intermittent anti-EGFR therapy. Is it something that you routinely started doing in the clinic? Can you elaborate on how you actually implement this in practice?
I missed your sentence. Sorry, it was disturbed. Might you repeat, please?
So you did talk about intermittent anti-EGFR maintenance therapy. So have you started using it routinely in your clinic, and how do you implement the strategy of doing intermittent? How frequently do you do liquid biopsies, and what kind of panel do you use on the liquid biopsy? Do you look for only presence or absence of mutant RAS, or do you look for the other drivers that actually might be coming up? So what is it that you really do in this kind of situation?
Regarding intermittent treatment, we had a clinical trial, and according to the results of improved trial, we know that it's a good strategy for left-sided patients with a low burden of disease. So we can consider intermittent strategy in such kind of patient, because we consider right-sided not candidate to anti-EGFR in general. And the design of the study was including right-sided too. Regarding liquid biopsy, we use it not in all patients, but in selected patients which we want to have rechallenge strategy, basically. Or if we have very long responder or early progressor, so in selected way, because in this moment we do not have a clinical trial on liquid biopsy, so we cannot propose it on all our patients. But we basically look at RAS, BRAF, and if possible, we use an extended panel, but repeat is not clinical practice.
Okay, so using that strategy is still not clinical practice at this point in time.
Yeah.
But would you be so let's say somebody on that strategy comes up with a druggable target and you're running a clinical trial for that, would you re-challenge with the anti-EGFR, or would you be tempted to enroll this patient on a clinical trial? Because that's
totally yes. I would use it for a challenge, but to include a patient in clinical trial, you need usually on tissue, the biomarker on the tissue.
Okay.
Unless the clinical trial do not include the patient based on liquid biopsy, but I do not have such trial right now in my center.
Okay. Dr. Daniel, is that the strategy in your place also, wherein you will do a liquid biopsy in selected patients, not all patients, especially ones who are having a prolonged response to the anti-EGFR therapy? What do you do in your clinic?
Okay, in my clinical practice, really, we use the liquid biopsy just clinic outside the clinical practice, but just in the case of a rechallenge. So if I want to make a rechallenge with an anti-EGFR, I can use the liquid biopsy. Otherwise, it's not my clinical practice, and obviously outside the clinical trial. So if the patient is not in a clinical trial, I just use in a rechallenge setting and nothing more.
Okay, very good. So Dr. Dirk, what would be your third line therapy choice? Let's assume that this lady has progressed. She's received an anti-EGFR initially, and then actually this patient progressed and she went on to have bevacizumab and FOLFIRI. That's what happened to the patient when this lady actually progressed. And then when she progresses again, what would be your choice of therapy? Let's say FOLFOX anti-EGFR progression, FOLFIRI bevacizumab progression. How do you approach this third line therapy in this patient? Would you go off to TAS-102, regorafenib, or do the liquid biopsy and get back to an anti-EGFR agent? What would be your strategy in that situation?
Great question, various factors. So let's say having the anti-EGFR resistance or non-resistance via ctDNA available would help, but it's not a prerequisite, as we know. and also some information about toxicity are important. So have toxicity resolved from anti-EGFR and oxaliplatin? That's the second. The third is, how long has the interval with FOLFIRI bevacizumab been? So how long has she been on treatment? If this has been a relatively short time, then I would, let's say, go for another treatment option like TAS 102. If this has been a long time and she had the option to resolve from toxicity, then maybe reintroduction may be also a situation. But if she would be, let's say, rapidly progressing after initiating the second line treatment, then it would be a further line treatment. Hopefully something experimental, something nice for a trial, etc. But otherwise it would be trifluridine tipiracil.
Okay, so your choice, a simple, straightforward choice would be to trifluridine tipiracil, but otherwise you would consider, because, you know, like we always keep discussing, we just have a couple of chemotherapeutic agents, 2 monoclonal antibodies, and you try to juggle around with all of these as long as you can before you jump to regorafenib or TAS, 102, because of the limited number of agents that you have in treating metastatic colorectal cancer. Dr. Jerry, Dr. Chanyut, your final remarks before I conclude. It's 7 p.m. here.
Yeah, I totally agree with Dr. Arnold. So I consider the toxicity profile, disease-free interval from the last time that they received their treatment. And I will also consider doing a liquid biopsy, not only for the EGFR rechallenge, but perhaps to look for other druggable mutation that was not initially seen in the prior liquid biopsy testing.
Dr. Jerry? Dr. Jerry, are you around?
Yeah, Dr. Senthil, I'm done.
Yeah, please go ahead. Are you also using liquid biopsies to, look at rechallenging patients with anti-EGFR drugs?
Yeah, outside of that, I also try to look at other potential mutation that was not initially seen and that could be perhaps a potential therapeutic target.
Okay. So we are starting to do more liquid biopsies, it looks like, and though it's typically not something that's part of the guideline to be used routinely in the clinic, we all seem to be using it in order to choose our patients for rechallenging them with anti-EGFR agents, primarily because of the limited number of drugs that we have, and patients living longer, needing more choices as far as therapy is concerned. So I think we will learn to use that strategy even better. Should you be doing only RAS? Should you be doing a wider panel, as Dr. Jerry said? And as our Italian colleagues clearly said, if they are running a clinical trial, they would do a wider panel and see if that patient is eligible to be enrolled on a clinical trial, because that's how you would learn and make your patient potentially live longer. And that's exactly what all of us are trying to do when you treat our patients, irrespective of whether it is colorectal cancer or any other malignancy. We're running short of time here. I still have a couple of points to discuss, but I won't keep you waiting. It is time. Thank you so much, all panelists, for patiently answering all the questions that we discussed today. Some of them might have been very elementary, but I think these elementary questions are the ones which end up being the most interesting ones, and real life cases make panels even more interesting. Thank you so much, Dr. Daniel, Dr. Claudia, Dr. Arnold, Dr. Jerry, Dr. Chanyut, our own Dr. Somashekar, and Dr. Omunde. It was a pleasure having all of you on the panel. Thank you so much. Good night, and hand it over back to Dr. Harsh for the concluding remarks. Thanks, all of you.
Thank you, Senthil. Fantastic panel.
Sure. And thank you, Dr. Senthil. And so again, I would like to thank ISMPO for organizing this meeting, Dr. Senthil, Dr. Vineet, and Dr. Chetan Deshmukh for chairing and organizing this whole agenda. And Dr. Arnold Dirk, Dr. Claudia, and Dr. Daniel Rossini for giving some spectacular presentations. And of course, our esteemed panelists as Dr. Chanyut, Dr. Somashekar, Dr. Omundi, and Dr. Jerry Tan. And of course, I'd like to thank all the people, all our audience, the colleagues who could join from different parts of the world. Sorry, Doctor, I could see Dr. Chetan Deshmukh. So, Dr. Chetan, do you have any final remarks from your end?
I think it was an excellent meeting. We discussed so many things. In the past couple of hours, we've been discussing not only about molecular oncology of colorectal cancer, moving from sidedness, maintenance strategies, newer molecules. Excellent. I mean, it had everything. It was really a complete meeting.
Okay. Yeah, I mean, I won't keep you all waiting after this. And thank you so much for joining for this meeting. It was wonderful having you all over here. And if it is possible for my other faculty members, if it's possible to switch on the video and we can have one snapshot. Okay, so I'm sure my colleague from my friends from my side here, they will be taking a picture and of course we'll share it with you all. Thank you so much, and I wish you all a very happy weekend.
Thanks so much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Bye. Good night.
Good night.
Thanks.